Hi, it's Jerry Roberts, and I'm back with our latest in our series of community conversations with people who are working on the coronavirus. And this morning we are honored to be joined by Thomas Tighe, who is the president CEO of Direct Relief, based out in a big old warehouse in Goleta. Thomas, thank you so much for coming. You have been the president and CEO of Direct Relief since 2000. That's correct. Before that, you were the chief operations officer and chief staff for the press corps, yeah, right, for the Peace Corps.
Right.
I'm mixing my metaphors here. Worked for the late Senator Cranston. Grew up in Palo Alto and went to UC Berkeley. That's probably an issue best dealt with in therapy, but that's okay. Tell us what Direct Relief does and specifically what you're focusing on in the coronavirus pandemic.
Well, first, thanks for having me on, Jared. Really appreciate it. Direct Relief has been around since 1948. So it's a humanitarian medical assistance nonprofit. And the model is really to make sure we try to mobilize private resources for people who can't afford the care they need. We work extensively trying to equip and support both the clinicians and the patients at the nonprofit safety net in the United States, like the Santa Barbara neighborhood clinics being one of them, which is where we started. But there are thousands in the United States, like the neighborhood clinics, that do such important work every day, often invisibly, except for the patients who rely on them. So that's a big effort on an ongoing basis throughout the United States. Internationally, there's a big network of partners that we try to support, with the main resource being stuff, medications, vaccines, medical supplies. So we do that every day and tend to get attention when an emergency happens. But really, the only difference in an emergency from our perspective is the kind of the scale and the pace of what we do. It's really what we do. We just do more of it faster, including now with the coronavirus, where it's been PPE initially, but there's also all sorts of other things that were chronic issues before that remain important to deal with, and medications related to the care of people who find themselves seriously ill in an ICU. So we're trying to do whatever we can to bolster, bring new resources to bear to to address the chronic gap that existed, and also fill these new gaps that have been brought about by the coronavirus for things like protective gear, medications, financial support, and the information products. We have a strong research and analysis team that's been really busy for the last 100 days trying to size and understand and bring some insights into how this thing is unfolding.
You've worked obviously on a lot of disasters, both in the United States and around the world. Have you ever trained for or seen a scenario for a pandemic of this scope and size? It's basically in every country. We have no immunological resistance to it. How would you describe the scope of it?
Well, yeah, I haven't. I'm not sure many have something of this scale. I think there's some sort of proxies with Ebola most recently, SARS and MERS, but those were relatively contained. Most emergencies that we end up dealing with are geographically distinct. So you have a Hurricane Maria or Hurricane Harvey, where there's a huge need because of an event and for the infusion of resources of all types. And usually you can mobilize resources from other places and bring them to bear on where the problem is. So among the challenges in this situation is that it's a simultaneous emergency everywhere, where everyone is dealing with and wanting the same supplies from our lens at a time. So you have a spike in demand and a contraction of supply because of the lockdown in China, and a further contraction of the supply chain just logistically as the economies have frozen up and the economic consequences have kicked in. So this is about as bad as it gets. I think the only good news, if there is any, is that we're very good at distribution as a species. I mean, this is one thing that kind of epitomized by Amazon, where most emergencies are in one part a logistical challenge because supply chains get broken in an area. But in general, we are very good. The advances in distribution technology and logistics driven by information availability, I think, give us a lot more tools to address this. It's just trying to get things unlocked and deal with it, because as you can see the pacing and the transmission from China to Europe to the US, and the large concern now is the southern hemisphere that has a lot of developing economies and countries with relatively thin health systems. They're looking at how the richest cities in the richest states in the richest country in the history of the world are struggling to manage this, with a big gulp, thinking, well, how are we going to deal with it? I mean, Seattle, New York, Palo Alto, Los Angeles, these are major crises for these health systems and communities. So it's very sobering to think of how this is going to play out. So we're trying to devote some mind space and resources to get in front of it as best we can, as the virus is expected to move southward in the next few months.
Can you walk us through sort of your thinking about it and your awareness of the virus from when it first appeared in China or even before, and how we got to today? I know, again, I guess you were sending supplies to China at the beginning, correct?
Right. And that was completely unexpected. You know, we do our best to forecast how the year's going to look, and helping in China was not part of it at all. And so when we, mid-January, I think when we first got we were aware of the outbreak. It was sort of there's this new flu in China, in Wuhan, but it was probably third week of January, I think, where we were put in touch with the Wuhan Union Hospital, which is sort of like a UCLA size, 1,000-bed tertiary care hospital with cancer and all sorts of the subspecialties. And they were clearly anxious because that was the kind of the ground zero. So the director of the hospital was asking, somehow he knew that we had a stockpile that we thought was substantial of PPE. And for years we've been manufacturing our own NIOSH approved N95s that everyone's heard of now. And we did that only because the state of California almost burns to a crisp every year. And every year the public is encouraged to, protect yourself by getting these N95 masks. And as soon as they're encouraged to do it, they're stocked out or being scalped. So, we've seen this. So we started having our own manufactured in China, went through that process. But we told the facilities in China, we don't know if we're going to be able to do it because China is not really welcoming foreign assistance. In my Peace Corps days, we started the Peace Corps program in China. But there's kind of that backdrop of history and Cold War tensions and some suspicion. So we had very little expectation that would actually work. It turned out it worked really because of the relationship we have with FedEx, that they did need the help. We had it in stock. We understood how important it was to move fast once there's an infectious disease outbreak, to get in front of it. So we were happy to help, but as the events unfolded and the size grew, we told them, we need to reserve the remainder of our supplies. We think we have other obligations here in the States. We think it would be, we're buying material from China, so you have the resources to put at this problem. And so we backed off, and probably by mid-February, we were backing off of assisting in China after multiple charter flights, and then really trying to get positioned to deal with what has happened. Really, what would we do when the virus arrived in the United States, which was basically to prevent what had been happening in China, get in front of it as best we can, protect the health workforce so they don't get sick, and both protect the frontline health workers and the neighborhood clinic equivalents, and then backstop the hospitals as best we can.
So did the first call in the United States come from Seattle, where the first outbreak was?
Yeah, so the first cases were detected, I think, in Seattle. There was one in Los Angeles, up in Northern California. And our approach was that we were thinking in terms of the frontline primary care health centers, because typically in emergencies, people, we're all basically at risk in emergencies, but some much more so than others. And, you know, the thumbnail is that the people who are vulnerable in emergencies, or most vulnerable in emergencies, are the same people who were most vulnerable the day before. So the low income, often people with low incomes, don't speak the principal language, people on the age extremes who don't have access to health or good diets and that sort of thing. That is basically the clients and patients of these community health centers, nonprofit safety net in our country. So that was our first orientation. We infused PPE to the Seattle surrounding nonprofit community health centers, thinking that that would be very good to keep them intact. Then it was Los Angeles, then it was Boston. I think it grew. So we had to step back and see how we could apportion what we had kind of more, a little tighter than we had been. And then worked with the hospitals, you know, that were seeing the first cases arrive, and they were short on PPE. So it was really a two-track system of supporting the front line and backstopping the hospitals. And Directly for years has worked with the state of California here on emergency kind of supply chain when things need to be moved fast. We have a big capacity building now. We have cold chain capacity for things like vaccines. And we have now a 155,000 foot warehouse with significant surge capacity. So that's sort of been our approach. It's just gotten a lot bigger. We've helped now 84 hospitals around the country. Since January, for us, our operational tempo has been far in excess of anything since I've been here or before that. So just really trying to keep the flow going from the private philanthropic resources and working alongside the government as they're really struggling, trying to, you know, get the resources that the public resources to where they need to get to. But that's not something they do every day. The government doesn't run the medical supply chain in the United States. It finances it, it regulates it, but it doesn't run it directly. So we understand that, and that's always one of the tensions that arises. But you know, we're just a support organization at the end of the day, and I've really been happy that we can at least focus and do something productive.
I think a lot of people have been shocked by seeing major cities and big medical centers in major cities all but overrun with cases. Is that because of the fragility of the supply chains? Is that because there wasn't enough thought put to stocking up for an event like this? What you know, how do you explain, you know, these amazing images that we've seen?
Yeah, I think it's probably a combination of factors. It clearly wasn't in anyone's scenario planning for 2020. I mean, they just didn't anticipate, and understandably so, a global pandemic that would overwhelm every health system that is confronted, except perhaps China, where they were able to exercise really severe social controls that, you know, we're having a milder version of what the enforcement, when you have a strong central government with kind of not all the privacy issues that we have here, they were very aggressive in enforcing kind of the stay-at-home policy, quarantined for weeks at a time, and they would enforce it. So, but from a health perspective, you know, there's this just-in-time model that we all have. Businesses don't necessarily like to stockpile things because, you know, the current practice is you show me your purchase order, then I will go back up my supply chain and I'll deliver it fast. So you don't want to have inventory made that people aren't going to buy, holding it at an expense to you if it's not going to sell. So the logic of the commercial world is, you know, just in time, which works great, except when it doesn't. When you have an unanticipated spike in demand, the production and the supply chain needs to flex up. In this case, when that happened, the demand spike occurred when the supply froze up and the supply chains contracted. So that's really caused a major, severe shortage of PPE and everything else. Some products like ventilators, there's a production lag time too. You just can't, you know, snap your fingers and have them. So that lag time in the production to catch up with the demand has been a further added kind of barrier for some of the specialized products.
But I guess everybody also assumed, I don't know, everybody, a lot of people assumed that the federal government had stockpiles of PPE and ventilators and equipment of that sort. Why has that not borne out?
Well, again, I think the after action reviews that are inevitable will probably tell a better tale. My sense is that the Strategic National Stockpile is kind of a warehousing program. So they do have stockpiles and warehouses, but some of them, clearly they were dated. State of California has its own version. They had 20 or 30 million of the respirator, just the masks, the face shields, they were all expired. I mean, some of them were still good. They had them retested, but so they had stocks, but it was a warehousing plan, not a rapid distribution plan. And I think it's a challenge for, we do distribution every day. So I think it's kind of an in and out. It's a high volume. You have to have systems and practice every day. It is really hard to start in a crisis doing anything at scale if you don't do it every day. So, for here in California, you can look at the firefighters and the law enforcement. Every day they're operational. They're really good. They scale up, they fold together when these wildfires break out. I mean, it's extraordinary. These are public servants who are operational every day. They don't get fazed by these situations. I think in the stockpile program at the federal level, the federal government is not running a health system. It's not running these daily operations. So it's really hard when this unprecedented scale of activity, they've got to take over the supply chain. I mean, I think that's how I understand it. It was a little clunky. The practice and repetition isn't there. It was an unprecedented scenario, and there hadn't been the investment in replenishing and swapping out the dated material to get new material in, as well as the scenarios that whatever the stockpile estimates were based on. This is far larger in scale. So it's a combination of factors that clearly has been a big struggle at every level, which has been pushed it to states and cities and almost kind of an every state for itself kind of an approach, which is really unfortunate because it just wastes time and effort and actually causes prices to rise if there's competition among people in the same country to buy the material.
And then, as you mentioned, this paradox of a lot of this, maybe most, is manufactured in China, shipped from China elsewhere, but yet you were supplying stuff at the front end of the pandemic to China. So it just seems like that supply chain issue is something that, as you say, would be referenced in after action reports about, is just in time really the right model, particularly for medical supplies and things of that category. Can you talk a little bit about what you're doing in California and also what you have done in Santa Barbara?
Yeah, I think California, it's been, we started what's now the largest program in the country for charitable medicine here in Santa Barbara. Just seeing that we're a wealthy community, but not everyone's wealthy. There are gaps, and people need help. And so our orientation of if there's these gaps in Santa Barbara that we can help fill because of the access we have to medication resources or supplies, it's probably likely it exists in places that are less well off than Santa Barbara. So that was 15 years ago.
And about in the pandemic, what have you been doing? Anything?
Well, I think it's basically what we've been doing everywhere else. We've supplied, Cottage and all of the facilities in Santa Barbara with our own inventory of PPE. We tried to make sure that they were well equipped. We understood the shortages were severe. And, we always try to look here locally, what resources, put on your own oxygen mask first. I mean, this is our home. This town has carried direct relief for 70 years. So that's we put that in a special category. So it's been medication and medication modules that we developed with a lot of international expertise. Those went to Cottage. So they had backstop for the medications for patients who were found themselves in ICUs. We bought 3,000 of these portable oxygen concentrators from Inogen, which happens to be right up the street here, because the signal from China was that the availability of oxygen for recovering patients was really important. And they had asked us to send some because they were trying to liberate free up beds in ICUs for recovering patients who could be discharged safely if only they had oxygen supplementation. So with the benefit of what we had seen in China, trying to model what we could do here, working with Sansom, the neighborhood clinics, and Cottage, and we were really fortunate that at every level in Santa Barbara, we have a really strong primary care system with the neighborhood clinics. We have a unique clinic in Sansom that has both primary care, it goes up to subspecialty care that's not hospital care. And then we have Cottage, which is a very fine tertiary care hospital. So thankfully, Santa Barbara is well equipped. It has very dedicated public health employees as well. But we were trying to bring in private resources based on what we saw, make sure that the PPE shortages did not kick in here, that we could help fill. And then we've created some programs recently at 100,000 masks just to make sure the essential workforce who's going to work in grocery stores and other places, we're making just the PPE available to them too, hoping that we can expand that to the general public. We think some of the materials that aren't suitable for a clinical setting might be superior to the hand-sewn masks or people just with a sock and a rubber band around their head. We think we'd like to do that expansively, at least in Santa Barbara, because we live here. We couldn't do it for all 330 million people in the United States. But and we will also be making some financial commitments that we'll announce next week, just because we understand that as money that direct relief is fortunate to have, it's not for direct relief as much as for the people and communities we serve. So we'll be making $1 million announcement next week to shore up the philanthropic support to the Santa Barbara health system.
And there you have it. Breaking news on newsmakers. Okay. Well, how the Governor Newsom has gotten a lot of good reviews for the way that he's handled the pandemic in the state. Have you had a lot of contact and supplying things via the governor's office?
Yeah, we've been in close touch with the governor's office. We work a lot with the California Department of Public Health, as well as the governor's Office of Emergency Services on an ongoing basis. So I think recognizing that the big wheels of government sometimes take a little time to get going, we did have supplies. We were coordinating, as we do, telling the state what we were doing to now several hundred facilities throughout California with several hundred deliveries of PPE, just so they knew what we were doing, so there would be no duplication. And so regular reports to the governor's office, offering assistance if we can help with the distribution here in California, obviously, because we're set up to do that, sharing our available inventory with them. And in several weeks ago, we were getting referrals directly from the state to help with kind of the establishment of testing sites up in San Mateo County, Stanford Hospital. So we were responding. The state had referred some requests to us that they weren't in a position to fill at the time. And so, that's nice to do because it's bringing private resources to bear, not expecting the public agencies that weren't set up to do this are going to be able to do it immediately and perfectly. So let's bring to bear all the resources in the state, including those that Direct Relief has. So we're happy to do that and continue to be in touch with the governor's office, Office of Emergency Services, and our former public health officer, Charity Dean, is now a very senior member of the California Department of Public Health, and we know her well, and she's been terrifically involved helping figure out the state plans for the response.
And she is in charge of the testing component. And everyone I've talked to on this series has said, we got to get tests. When are we going to get tests? We need to have a more robust test system. Can you give us the benefit of your analysis for what has gone wrong, why we don't have enough diagnostic tests, let alone serological antibody tests so we are still locked up, so we can't reopen our economy?
Yeah, I think it's one of the, there's a lot of tests. I think it's a novel coronavirus. So I think just getting it dialed right so you weren't getting false negatives or false positives, really the science behind how to isolate and make sure that it's an accurate test and then scale it up, I think has been a challenge. The German test that has seem to work well. I think that's the protocol. The approach is seemingly working well. It's been adopted in the Pan American Health Organization for Latin America. But I think that the rapid attempts to develop some tests that were scalable, we had some misfires, I think.
With the CDC?
Yeah, and kind of the testing capacity. There's ranging from the lack of a test and the attempt to many people trying to develop a test, the lack of testing supplies, including just the cotton swabs, which machines with which reagents are suitable for which tests. It's a lot of complexity here. There wasn't one particular test that everyone rallied around and leaned into and perfected. It's been kind of this entrepreneurial thing, and I think it's going to be good. I think a lab-free test, I mean, for years, Direct Relief has been the principal channel for, it's called the Determine Rapid HIV Test Kit. So this is one drop of blood wiped on a card with no labs at all, but an immediate 15-minute diagnosis of your HIV status with a very high reliability and very few false negatives or positives. So we know how to do that. This is novel. I think right now we're trying to figure out exactly the approach for really the antibody test, I think is what people are leaning to. But I think we're getting closer. The testing capacity from reagents to machines required and the supply chain for that had to scale up, but it's clunky and there's a lot of people involved. And again, it's one of those things that it's tough for the public health system in the United States that is largely regulatory, advisory, informative, not operational, to deal with, an operational approach to test 330 million people or 40 million people in the state of California. They're not staffed up to do that. So it has to be a collaborative effort with the private industry, academic community, the private distributors, the corporate sector that makes all this stuff. And it's taken a little while to get that sorted out, but I'm hopeful, just given the wealth of talent, resources, knowledge, and systems that we have to bring to bear, we should get there soon. I'm hopeful. We usually do, but it has been clunky than anyone would have wished. Obviously, we have millions of people who are not tested, and it's been very parceled out as a result thereof. So a lot of people don't know their status, which has all sorts of implications for when you can back off the social policies.
Right. And of course, we see the mayor of LA saying now anyone in LA can get a test, and obviously they've had much more surge problems than we have here. But I think people remain very confused about that. Just real quick, I want to ask two questions. One is, what do you see on the horizon for, say, the next 3 to 18 months about how this is going to go, and what scares you the most about that?
Yeah, well, 18 months is a little bit out there. I think the next 3 months, we're looking at what signals will give us confidence that we can start to ease off really the government has had one lever to pull. Stay at home. It's a big lever. That's, and only they can do that. They're the only authorized body. Governments around the world that have faced this have all largely, except Sweden, pulled the big lever of just stay in place, right? While we're trying to figure it out. That's a severe control. It makes a lot of sense just to avoid transmission, but you need to, that can't be sustained forever. So I think the governor has outlined the 6 conditions under which we could start to open segments of, commerce and society, I think are generally the right ones, but each one has complexity built into it. So I think in the next several months, we will see testing expand. We'll see a normalization of the health services, which have been really focused almost exclusively on COVID-19. There's real concern that there's pent up deferred services that are increasing the burden of disease for people with chronic illness, delayed surgeries. So that has to, I think those, that will be eased a little bit to really get health services bootstrapped or back online. And the economic kind of realities of, shutting down, basically freezing the entire economy are severe. And so the risk is preventing, you don't want the treatment for COVID to be causing problems that cumulatively could be larger in other respects, including in health and the economic repercussions. So I think that's so clear. That's the debate going on right now. And that trade-off between what's important to prevent disease spread and what's important to reactivate the economy, there's clearly tension there. And I think that's a tough policy decision. And I think the governor has been very clear. He's, seems very strong and certain. And I really appreciated his outlining at least the conditions of what the steps will be to reopen and normalize, in whatever the new normal is going to be. Each one of those steps is going to be hard to do.
Yeah. And then just to circle back on something you said earlier about concerns about the Southern Hemisphere, and is the pandemic going there next? Is that a catastrophe awaiting to happen?
Yeah, I hope not. But again, I think that's the big concern. We've started, it's been difficult to really the mind share devoted, to talk about Mozambique to someone who is worried about their grandmother in a nursing home in Seattle. Get back to me later has basically been the message, and understandably so. But we are in close touch. We've been working with probably 20 or 30 countries already that we have ongoing obligations to, and we've sent our initial tranche of PPE to Mexico, to the Caribbean, to Africa, to Latin America. We're part of the ASEAN, kind of the Association of Southeast Asian Nations. It's like they're mini UN, and we're part of that structure for emergencies. So it's the front end. They've learned a lot from the experience that other places have had, but the mobilization of resources and application to those lower income countries is going to be a real challenge, particularly when the prices for things like PPE have spiked. So we're working both with the regional partners like the Pan American Health Organization, but hundreds of groups that we know well in these countries, and trying to make sure that, they're not forgotten. We're going to keep the regular support that they always need going as we try to mobilize the private resources. Clearly, I think one of the signals, the U.S. is the largest funder of the United Nations. It's the largest funder of the World Health Organization.
Or was.
Bilateral funder of foreign assistance in the world. And I think right now the signal has been from the current administration that is not a priority, which is good to know because it causes us to think, well, then we need to mobilize private resources, get the corporate sector involved, academics involved, and really have a much more thoughtful plan of how to get the resources assembled and optimized in getting them out there, because the public agencies that we typically look to at the UN, the World Health Organization, they're wobbly. They're not funded well, and they're looking at a huge crisis. So it requires an adjustment in thinking, and really we're all in it together. We are, and I think we need to make sure that we are all in it together, not state by state, county by county. It's a common global threat to every person on this planet, and we need to do whatever we can to help the people who are least fortunate and, are likely to suffer the worst consequences if nothing is done to assist them. So that's what we're trying to do. I think that will grow our international assistance as things get normalized here in the U.S. And a $2 trillion, infusion of, financial resources for both health and everything else kicks in to turn our attention and try to do something as best we can for the countries who are looking at a really scary scenario in the coming months.
All right. Thomas Tighe, thank you so much for being with us and sharing your information and insights. And I have a feeling this is going to go on for a while, so hopefully you'll come back and speak with us again. Thanks for your time.
My pleasure. Thank you very much, Jerry.